All right, class, welcome. Today we are going to tackle a very, very important topic, anti-Parkinsonian drugs. Now, I'm not just going to give you a boring list of names and mechanisms. No. We are going to understand the strategy. We'll follow a patient's journey from the beginning to really understand why we choose which drug and when. So, let's get started.
So let's start with the basics. What is the fundamental problem in Parkinson's disease? What is the core issue? Well, it all comes down to one chemical. You know it, dopamine. In a very specific part of the brain, the neurons, the little factories that make dopamine, they are slowly dying off. And it's this loss of dopamine that causes all the trouble, all the symptoms we see.
Okay, so this brings us to the most important question, the puzzle we as doctors have to solve. The patient's brain is running out of dopamine. So how do we get it back in? It's a simple question, right? But the answer is the key to this entire chapter. How do we solve this supply problem? Now, to fight this problem, we have a main weapon in our arsenal, our hero drug. This is the gold standard, the most effective thing we have to give the patient relief, and its name, levodopa. But, like any good story, our hero has a big weakness, a flaw.
So how does this levodopa actually work? I mean, how does it solve our supply problem? See, the brain is like a VIP area with a very strict bouncer called the blood-brain barrier. Dopamine itself, it can't get past security. But levodopa is clever. It's a precursor. Think of it like a raw material or a Trojan horse. It has the all-access pass to cross the barrier. And only once it's inside the brain, it gets converted into the dopamine we so badly need. Genius, right? But wait, there's a catch.
And here is that big flaw I was talking about. This is the problem. If you just give the patient levodopa by itself, a huge amount of it, we're talking up to 99%, gets converted into dopamine outside the brain in the rest of the body. And this is bad news. It causes all sorts of nasty side effects, nausea, vomiting, heart problems, and hardly any of the drug actually gets to the brain where we need it. It's so inefficient. So this is not a good plan.
So we need a better plan. And that plan is teamwork, the power of combination. Our hero, levodopa, gets a sidekick, a bodyguard. And the name of this bodyguard is carbidopa. Now look here, what carbidopa does is very smart. Its job is to block levodopa from changing into dopamine outside the brain. And the key thing is, carbidopa itself cannot cross the blood-brain barrier. It stays outside, in the periphery, protecting levodopa on its journey. The result? Way more levodopa reaches the brain where it can finally do its job. It's a brilliant strategy.
And the benefits of this combination? They are massive. First, we can cut down the levodopa dose by almost 75%. That's huge. By stopping that conversion in the body, we get rid of most of the nasty side effects, like the nausea and cardiac issues. And inside the brain, the dopamine levels are much more stable. The whole therapy just becomes so much more effective. This is exactly why you will almost never see levodopa given alone. Its bodyguard, carbidopa, is absolutely essential.
Okay, so for the first few years, our patient is doing great on this combination. Life is good. But we have to remember, Parkinson's is a progressive disease. It doesn't stop. And the treatment that works so beautifully at the start, it will eventually start to have problems. Our patient's journey is now entering a much tougher phase, full of long-term challenges.
This timeline here shows you what typically happens. For the first 2 years, maybe, symptom control is fantastic. We call this the honeymoon period. But then, things start to change. Fluctuations begin. The patient starts feeling the medicine wearing off before the next dose is due. After 5 years or so, it gets even more complicated. You see this on-off phenomenon, and a big new problem comes up, dyskinesias. These are these strange, involuntary movements, and they are caused by the drug itself. They become a huge problem to manage.
So what exactly is this on-off thing I'm talking about? It's literally like a switch being flipped. When the patient is on, the drug is working. Their symptoms are controlled, they can move around, but, and this is the problem, this is often when they get those horrible dyskinesias, those extra movements. And then, just like that, the switch flips. They go off. The drug's effect just disappears. The stiffness, the tremors, the inability to move, it all rushes back. The patient is disabled again. You can see what a terrible dilemma this is for us to manage.
So, when we reach this advanced stage, our hero drug and its bodyguard are not enough. We need to call for backup. We need to bring in the specialists. This is our supporting cast of drugs. Now remember, we don't use them to replace levodopa. We use them to support it, to help us manage these very difficult long-term problems.
First up in our supporting team, we have the dopamine agonists. The name gives you a clue. Agonist means it helps. So think of these drugs as mimics, as impersonators. They don't need to be converted like levodopa. They go straight to the dopamine receptors in the brain and stimulate them directly. Basically, they pretend to be dopamine.
The main examples you need to know are ropinirole and pramipexole. Now, for younger patients, sometimes we start with these drugs to try and delay using levodopa. Why? Because the big advantage is they are less likely to cause those troublesome dyskinesias. But, and this is a big but, there is a trade-off. These drugs have a much higher risk of causing psychiatric side effects, things like hallucinations, or even suddenly falling asleep during the day. So we have to be very, very careful, especially with our older patients.
All right, next group, the MAOB inhibitors. These guys are the protectors. Let me explain. Inside the brain, there is an enzyme. Its name is monoamine oxidase B, or just MAOB. Its job is to break down and remove dopamine. So, what do these drugs do? Simple. They inhibit this enzyme. They stop it from working. And the result? The dopamine that's already in the brain, it's protected. It lasts longer.
The two main drugs here are selegiline and razagiline. Now, on their own, their effect is quite mild, but they are excellent as an add-on therapy to help levodopa's effect last longer. The key thing for you to remember is that razagiline is the newer and better option. It's more potent, and importantly, it is not metabolized into an amphetamine-like substance. This means it doesn't cause problems like insomnia, which can sometimes happen with selegiline.
And finally, our last group of specialists, the COMT inhibitors. I like to call these the extenders. Remember how carbidopa blocks one enzyme that breaks down levodopa in the periphery? Well, there's another enzyme out there called COMT, and it also breaks down levodopa. So these drugs, they simply block COMT. This helps to extend the life of each levodopa dose, making sure more of it is available to get to the brain.
And the perfect example here is a drug called entacapone. Now listen carefully, this is purely a helper drug, an adjuvant. It does absolutely nothing on its own. You only add it to the levodopa-carbidopa combination for advanced patients who are having those on-off fluctuations. And what is its main benefit? It increases the patient's on time and decreases that horrible off time. It just helps to smooth things out.
Okay, so let's put all these pieces together. Let's look at the master plan. With all these different types of drugs, the most important thing to understand is this. Treating Parkinson's is not about writing one prescription and you're done. No, it is a dynamic, constantly changing strategy that we have to address for each patient over many, many years.
So what does this journey look like in a real clinic? First, patience. We often wait to start drugs until the symptoms are really affecting the person's daily life. For younger patients, the plan might be to start with those mimics or protectors to save our best drug, levodopa, for later on. But when symptoms get bad, levodopa with carbidopa is still our #1 most effective treatment. Then, as the disease gets worse and those fluctuations start, that's when we bring in our supporting cast, the agonists, the inhibitors. And the most important point on this slide is the last one. This treatment is never fixed. We have to constantly reevaluate and adjust the plan.
And finally, this is something we must never, ever forget. None of these drugs, not a single one, is a cure. The underlying disease, the death of those neurons, is still happening. What we are doing is managing the symptoms. We are giving our patients an extra 5, 10, maybe even more years of a happier, more productive, and more functional life. And that is an incredibly important goal.
So you see, our strategy today is quite clear. We have a plan. We have our drugs to manage the symptoms. But that underlying process, the neurodegeneration, it just keeps going. And this leaves us with a final, big question to think about. As our knowledge gets better and better, what will the next chapter of treatment look like? What is the next big breakthrough that we are all waiting for? Something for you all to think about.